Welcome to Holistic Treatment of Dry Eye Disease, learning from the experiences of real-life patients. I'm Chiarelli. I'm a registered nurse and a counseling therapist with a private practice in Calgary. I'm also a dry eye patient. The focus of this webinar is excellence in treatment of dry eyes from the patient's perspective. I talk about my personal experiences as a dry eye patient, as well as the collective experiences of hundreds of other dry eye patients that I got to learn from as a member of a dry eye support group. I also use my professional experience in education. First, a bit about my dry eye story. I have had regular eye exams since the age of 8. Quite suddenly, in the fall of 2017, I developed dry eye symptoms. I was on a vacation in Arizona, staying in that little casita when my eyes became painful. I saw my regular optometrist in Calgary after I returned. I went a few times complaining about how awful my eyes felt. I was prescribed steroid drops and advised to use a heat mask and artificial tears and take omega-3 fish oil. These made no difference. My optometrist said maybe I need to be referred for LipiFlow. I looked into it, but because of the long wait time in Calgary, I found a dry eye specialist in Arizona, seeing as I was going there anyway. I was diagnosed with MGD, with severe gland atrophy, ocular rosacea, and aqueous deficiency. I was treated with Blefex and LipiFlow. At home in Calgary, I religiously continued home treatment and waited for improvement. 2 months later, I was still suffering, so I started searching for dry eye treatments again and found IPL. After a very disappointing experience with the first dry eye specialist, I found another one. I had another Blefex and 3 IPLs with gland expression within 6 weeks. After each one, I felt a little bit better, and after the third one, my remaining glands were functioning again. Although I felt much better, I still had dryness. I tried punctal plugs without relief. I started researching again and found information from the ophthalmologist from my native land, Finland. They recommended sea buckthorn oil, so I ordered me some. A couple of weeks later, I had moisture in my eyes and it felt absolutely amazing. And now I was not just functioning in life, but also enjoying life. I then also started on an anti-inflammatory diet. I also noticed that physical activity helped. I used hypochlorous acid for a while, and I've had some further IPLs, once to unclog glands again, and also for treatment of rosacea on my cheeks. It has now been 19 to 20 months without IPL, and my eyes are doing quite well. I use artificial tears at bedtime only, unless I fall asleep prior to. I try to focus on complete blinks to keep the glands functioning, but overall I don't do a whole lot for my eyes, and I find the less I focus on my eyes, the better they are. I have noticed also that one of the most significant factors for me in the comfort level of my eyes is my emotional and mental health. This is from a website stating that you provide the most comprehensive and personalized dry eye treatment, and then listing artificial tears, prescription eye drops, steroid eye drops, punctal plugs, and warm compresses scares me. What if dry eye patients think that this is all there is? The DEWS report states, management of DED symptoms is complex and healthcare providers need to consider a patient's holistic picture rather than simply treating ocular signs. You know the definition of dry eyes. A multifactorial disease requires multiple treatment modalities. The body has the potential for healing and self-correction. When there's a loss of homeostasis, the body wants to get back to homeostasis. The question is, how can you help facilitate healing? Integrative medicine is needed. Integrative health and medicine combines best evidence-based practices of conventional Western medicine and complementary and alternative health. It is a whole person approach that includes the physical, emotional, mental, spiritual, and social aspects in an individualized way. Dry eye testing and diagnostics are obviously needed prior to any treatment. You need to be an investigator to identify the root causes of DED. The dictionary definition of root cause is the fundamental reason for the occurrence of a problem. For example, while MGD might be the cause of dry eyes, what is the reason for the MGD? When we understand root causes, we can not only treat the disease, but may also be able to do something to prevent dry eye disease. Don't make conclusions too quickly. For example, some dry eye patients say that their eyes feel better when they are on vacation on the beach. Is it the humidity or the vacation that makes the difference, or both? There's a long list of medications that have eye dryness as a side effect. Please review the medications that we are on, and if needed, talk to our prescribing physicians to explore alternatives, dose adjustments, etc. Please also teach us about the over-the-counter medications that cause dryness. There's also a long list of systemic illnesses, vitamin deficiencies, ocular surgeries, hormonal factors, and treatment for other illnesses that contribute to dry eyes. I'll specifically mention rosacea because so many of my fellow dry eye patients have said that their doctors have no idea how to diagnose ocular rosacea. Another common concern is the impact of hormones. For example, a mom whose teenage daughter has dry eye disease and also polycystic ovarian syndrome says that when her daughter is on progesterone, her eyes feel 100% normal and she can wear soft contacts all day. So while the hormone testing and balancing business is not in your job description, make sure you refer your patients to doctors who do make it their business and work with them. Do remember that you are the expert on dry eyes, so we expect answers to our questions from you. And please refer us to GPs for treatment or diagnostics for systemic illnesses. Psychological trauma, mental disorders, and emotional health factors contribute to DED because the mind and body are connected. It's interesting that while reading and computer use decrease blink rate, so does depression. I also find it interesting that DED, autoimmune diseases, and chronic pain are more common in females. What is also more common in females is psychological trauma. Research shows that trauma contributes to the onset of physical and mental illness, perhaps also a factor in DED. According to Dr. Laura Perryman, 85% of patients reported that their eye care provider never asked about cosmetics. Ask us about anything we are putting into or around our eyes. This obviously includes makeup and skincare products, but also patients are desperate and put some unusual things into their eyes. How do you respond? If your patient says, I use makeup and skincare products that are organic, vegan, ophthalmologist and dermatologist tested, hypoallergenic, gluten-free, and all natural. Is that safe for dry eyes? Or what do I need to know about shopping for cosmetics? We need our doctors to talk to us about makeup, eye creams, and skincare. Oh, and talk to your staff about those things as well. I've seen staff with eyelash extensions. Help us find dry eye safe products. Remember, makeup is important for many of us, so please do not dismiss its importance. What do these have in common? Inflammation. Diet, inadequate sleep, lack of physical activity, stress, anxiety, depression, psychological trauma, all contribute to inflammation. Inflammation plays a significant role in the development of dry eye disease, just like it does in many chronic illnesses. Mental disorders and stress may worsen dry eye signs and symptoms by promoting inflammation. According to psychoneuroimmunology, the nervous system, the endocrine system, the immune system, and the emotion centers are connected. Eyes are an extension of the central nervous system, so it would make sense that the eyes are influenced by the other systems. No part of the body, not even the eyes, exist in isolation from the rest of the body, and the body and mind are inseparable. All eye doctors need to consider the role of emotions. What is excellent dry eye treatment? We need competent dry eye specialists who use all evidence-based treatment modalities. If you don't have the tools and knowledge to treat, we need to be referred. We need personalized integrative treatment plans based on accurate diagnoses. If you don't have the equipment needed for treatment but have a prescription pad, you may be tempted to only write a prescription. If you own only one piece of equipment to treat dry eyes because you can only afford to buy one machine, it is tempting to use it for all patients because, after all, there are no real standards that tell you what is indicated. You may own more than one machine, but because there are no standards, you still may not know which one to use. So you start with one, and if it does not work, you try the other one. In the meantime, the patient is frustrated, disappointed, and out of a lot of dollars. We desperately need research into dry eye treatments. Here are a couple of quotes from real dry eye patients. There is more to dry eyes than just putting drops in our eyes. It takes a whole body approach in finding what works for each of us. I don't think most doctors take the time to go over all the different things that we can do at home to make things more comfortable. Most of us learned through groups on Facebook. And another says, having a doctor who has many things in his medicine cabinet that he can offer and who's willing to listen and try to find what works best for each person is the most important. There is not a one-size-fits-all. We need someone who's going to listen to our experiences and offer solutions and answers, even if it's just to say sometimes you have to work through the irritation and persist because it will improve. Please refer us as needed to fully investigate possible comorbidities that might be contributing to dry eyes. We have questions about lid hygiene. There are no universally accepted guidelines for lid cleansing, and peer-reviewed evidence is lacking. How often should lid scrubs be used? What about the use of topical antibiotics? There's also limited information on the impact of tea tree oil. How often should we have lid margin debridement, and is it even needed on a routine basis? The temperature of hot compresses and the time required is not established. When does one use heat and when cold? Many of us have spent a lot of dollars trying every drop available in the pharmacy. Not all artificial tears are created equal. Do you know which one drops to recommend and based on what? We have questions about humidity, moisture chamber goggles, anything to attempt to make our eyes more comfortable. We need to know about medications, their indications, benefits, and risks, as well as alternatives to medications. I have seen many dry eye patients on prescription eye drops when other treatments are needed. I find it concerning when patients are prescribed oral tetracyclines for treatment of rosacea because they are not able to afford IPL. Should patients be getting treatment with more side effects and risks because they cannot afford a safer treatment? There are many unanswered questions about advanced dry eye therapies. For example, should expression be done following IPL? Is it better to treat the upper eyelids directly with IPL? What is the ideal frequency of IPL? Should heat treatments be used for those with rosacea? Should IPL be combined with thermal pulsation treatment? If so, which one should be done first? When should probing be done? Is it safe? High quality studies are lacking, and many patients feel like guinea pigs, and it's scary. And there are more treatments and more questions. Personally, I'm waiting for my bovine gland transplants. Okay, let's talk about dollars. Dry eye disease is expensive. Some of my fellow dry eye patients have called it the disease of the rich. Sadly, not everyone can afford treatment. Please only recommend treatments and products that we truly need that have evidence. Advocate for us to get treatments and products, even artificial tears, to be covered by provincial healthcare and employer insurance plans. This requires research to establish standardized treatment protocols. Advocate for us to get workplace accommodations as needed in order for us to be able to continue working. Trial and error treatment is frustrating, disappointing, and expensive. It can lead to hopelessness and loss of trust. When I read the DUCE 2 report, I saw all kinds of statements about the need for further study. Who is doing research? For excellent care, we need information about food as medicine. Do you talk about an anti-inflammatory or a Mediterranean diet? Do you talk about hydration, caffeine, food allergies, foods that can trigger rosacea? Recommending omega-3 supplements is very popular, but do you let your patients know that supplements are not a replacement for a healthy diet? In fact, eating fish is probably better than taking fish oil, although most of us do not get adequate EPA and DHA from food. Is there an optimal dose of omega-3? Is there an optimal ratio of EPA to DHA? Do your patients understand the importance of the ratio of omega-3 to omega-6? I understand nutrition is difficult to study. We have questions about nutrients and supplements, many that I have listed here. When it comes to supplements, we need to know about the quality of supplements, therapeutic dosing, interactions of medications and supplements, as well as other medical conditions affected by supplements. You don't need to know it all, but don't forget about referrals to other healthcare providers to help. Do you talk about physical activity and how it can help with dry eyes? Just don't tell us what kind of physical activity we should do. Physical activity has to be something that your patient enjoys. Ask us about sleep. Many dry eye patients do not get a break from eyes at night either. Approximately half of patients with DED suffer from poor sleep. Sleep quality in patients with DED is significantly worse than in patients with other ocular surface diseases, and it is correlated with the severity of DED. For some, eyes do not close completely at night. Sleep deprivation may lead to more dry eye symptoms and increased risk of DED. Sleep problems can also be symptoms of mental disorders, and sleep problems contribute to mental disorders. Please take our discomfort and pain seriously. A patient says, so many of the doctors would look at my eyes through a slit lamp and tell me my eyes looked fine. This is very disheartening to hear. You are in so much pain and the doctor discounts it. And another patient says, nobody thinks this is so painful day by day for years. The doctors think you are hypochondriac and just invent the pain. This is my biggest frustration. We just want the pain to go away, or at least a break from it. Here are some facts about pain. Pain is subjective. We can have pain even if you don't see any signs of pathology. Symptoms in DED may not correlate well with ocular findings. Many with DED also have chronic pain syndrome or chronic fatigue syndrome. Most or post-traumatic stress disorder frequently coexists with chronic pain. Pain is a cause of depression and anxiety, and depression and anxiety can increase pain. Also consider the possibility of neuropathic pain. People with mental disorders or stressors tend to have an increased perception of and sensitivity to pain. People with chronic pain and mental health issues may have more intense symptoms of DED. And depressive mood can lower the threshold for perception of discomfort or pain caused by DED. People with mental disorders and stress are more prone to dry eyes. People with dry eyes have an increased risk of experiencing severe psychological stress and mental disorders. It's a vicious cycle. Eye symptoms cause depression and anxiety. Depression and anxiety make eyes feel worse. Effective treatment for DED can have a positive impact on mental health. A dry eye patient says, I think it's very important that these doctors stay plugged in a network with each other to learn best practices for patients that have the most severe cases. Many studies have found little or no correlation between the severity of symptoms and clinical diagnostic test results. When the cause of symptoms cannot be explained by exams and/or there has been an unsatisfactory response to dry eye treatments or treatment resistance in terms of persisting symptoms, consider mental health issues as one factor in causing symptoms. Do you ask your patients, how are you feeling emotionally? What is the impact of DED on your life? What are your concerns or fears? If you say you don't have time, then you aren't providing excellent treatment for DED. Lack of time may be used as an excuse when there's a fear of emotions and not knowing how to respond. For us, just being able to name our emotions to a person who shows interest and does not dismiss how we feel is so important and so very helpful. Remember that there's evidence that people who suppress emotions may be more likely to get ill and less likely to recover. Here are some quotes from dry eye patients about what living with dry eye is like. You can have a read through those. As dry eye sufferers, we grieve a lot of losses. The loss of health. We may lose activities that we used to enjoy. We may lose time with friends and family. We may not feel good about the way we look. We may lose productivity at our jobs. We may lose our ability to work completely. There are many young people with dry eyes who have had to interrupt their educational plans. Dry eyes can impact our relationships. There may be a lack of understanding from others or an inability to do social activities. We may experience guilt, for example, of not being a good parent. The cost of dry eye treatments affects our finances, perhaps combined with limited ability to work. We may experience a lack of meaning and purpose in life, which is clearly linked with depression. We can lose normal functioning in life, things that others take for granted, daily tasks such as reading, using a computer, watching TV, driving, and shopping. I felt that I wasn't accomplishing much in a day as I needed a real long sleep, or at least keeping my eyes closed for much of the day. I needed constant breaks. Spiritually, chronic illness can lead to an existential crisis. We may have many questions that I've listed here. I wrote in my journal, I'm looking for meaning in my suffering. What is this suffering supposed to teach me? What am I supposed to do as a result of this suffering? Am I wasting my life? But are any years really wasted? It seems like everything is being taken away from me. What is the meaning and purpose of my life? If I have no meaning and purpose, I might as well die. When there's physical and or emotional pain, addictions are a risk, especially if predisposed to addictions. People who have experienced trauma are predisposed. Addictions are a way to self-medicate physical or emotional pain. DED can cause much anxiety. I've given some examples here. How bad will my eyes feel when I open them in the morning? What's the weather like going to be? What's the weather like today? Will I get through grocery shopping? Can the treatment cause harm? Will my meibomian glands last until the end of my life? Will I go blind? Will my eyes be looked after in the long-term care facility? Dry eye disease is significantly associated with suicidal ideation, even after controlling for depression. What does this picture of a hummingbird have to do with suicide? Hummingbirds symbolize enjoyment of life. They also symbolize determination, flexibility, adaptability, and perseverance. In some cultures, hummingbirds are seen as healers. When I took this picture, I was sitting on the patio of my rental house in Arizona. I was experiencing what it was like to not want to live if I was not going to find relief. I was not actively suicidal because my family and my work kept me alive, but I did believe that only death could bring me relief from the agony of my dry eyes. In despair, I was counting how many years I still might have to live. I was worried about losing my career. I worried that I would just become a burden for my family. This picture was taken 2 days after my first IPL. My eyes felt horrible, and I don't even know how I was able to handle the trip to Arizona alone. Airports, the flight, and driving to the rental house. I did most of it with my eyes closed. I had designated this trip as a healing trip. Despite how awful I felt, I decided to live life again. With a syringe of saline in my hand, I set out to drive on the freeway on a road trip. Saline was the only thing I could tolerate in my eyes at that time. I had a session with a somatic experiencing therapist. I went on hikes in the desert. I had a massage. I did a workshop on EFT tapping. I saw a spiritual director. I remember words from a meditation. May I be filled with loving kindness. May I be free from suffering. May I receive what I need. May I be at peace. I attended a journaling workshop where the objective was to examine ways in which you can be in the midst of noise, turmoil, troubles, and still be able to heal and find the calm in your heart. I was reminded to be open to all sources of healing. I talked with others with chronic illness and pain. I made a new friend with whom I connected because our shared interest in shooting handguns, which I continued despite the state of my eyes. Back in Canada, I continued with IPL. After 3 treatments, my leftover meibomian glands were functioning again. It also helped with blepharitis and rosacea. But I still did not have enough tears, so I did more research and discovered sea buckthorn oil. About 13 months after diagnosis, my eyes were comfortable and I was enjoying life again. It has become quite apparent to me that what impacts the well-being of my eyes on a day-to-day basis is related to how I'm feeling emotionally. Many people see my job as stressful. There are issues that I deal with that no one should have to hear about. However, that is not what affects my eyes. I have learned to identify the more subconscious stressors that trigger my eyes to feel dry. We may benefit from various treatments such as these that I have listed. I want to especially mention connection with others with DED. Many of us have learned from other dry eye patients things that we would not learn from my doctors. And giving and receiving support is so valuable. I knew I wasn't alone in how I felt and what I thought. I mentioned earlier that it's important that we get asked about how we are feeling. It's also important that you respond. I heard about a survey that showed that if patients mention a physical symptom, doctors respond to it about 80% of the time. When patients mention an emotional symptom, 70 to 80% of the time, doctor does not acknowledge it at all. But as a dry eye patient says, a good dose of support and understanding cannot be overprescribed. Research shows that empathy is crucial to effective medical care. More than half of prescriptions and doctors' recommendations are not followed. The biggest predictor of patients following doctors' treatment recommendations is the level of empathy. Empathy is also needed when telling a patient about diagnoses. You can show empathy by identifying feelings and paraphrasing what you heard the patient say. Try to get the emotion and degree of emotion correct by putting yourself in the patient's shoes. You can show empathy by active listening and engagement with specific words the patient uses, as well as emotion. Nonverbal attunement can show empathy. Examples include eye contact, facial gestures, tone of voice, and movement of your hand. Are you already thinking about how to respond when your patient is halfway through a sentence? You may have seen this quote: "Most people do not listen with the intent to understand. They listen with the intent to reply." A study was done to see how long patients talked before doctors would interrupt. It was 23 seconds. And another study found that it was only 11 seconds. If you let patients talk about whatever matters to them the most, more than 90% are done within a minute. Another 5% within 90 seconds, and 5% take more than 90 seconds. Interrupting can be subtle, like asking a question, but interrupting says, "I'm in charge of the conversation, not you." Patients need educating, you know that. However, the way you provide information makes a difference in your patient's ability to understand. For example, lecturing, are you providing a lot of information at once, is not effective and will lead to you having to repeat yourself or your patient simply not understanding. What is effective is speaking a couple of sentences, stopping and letting your patient respond. What also helps is empathizing before educating. Patients are more likely to listen to you and trust you when they know you understand. It just makes sense. All patients need trauma-informed care. Therefore, all ECPs need to be trained in trauma-informed care. 76% of Canadian adults report some form of trauma exposure in their lifetime. Trauma comes in many forms, including experiences in healthcare. You do not need to know what type of trauma your patient has experienced in order to provide trauma-informed care. Trauma-informed care recognizes the prevalence of trauma and the impact of trauma in a patient's encounters in the healthcare system. It recognizes that survival stances of fight, flight, or freeze may be triggered in patients. The goal is to avoid re-traumatizing patients and supporting healing from past trauma. Trauma-informed care promotes a culture of safety, empowerment, and healing. Practicing trauma-informed care means that you and your staff help all patients feel safe. Think about what your patients need to avoid reliving trauma. If you see a fight, flight, or freeze response, understand that these are trauma reactions. Safety and trustworthiness are established through practices such as welcoming front desk staff, layout of physical space, words and body language that convey respect and acceptance. Trustworthiness requires understanding, transparency, consistency over time, and not abandoning. Trauma-informed care is about choice and voice. Your job is to give all the information needed. In order to improve your trustworthiness, provide resources and references. Don't forget that empathy helps with trust. To you, treatment is routine. It is not for your patient. Let your patient choose how they want to move forward. Choice also includes asking for permission before you do anything. If a patient refuses any exam or test, do not attempt to force them or do not educate more about the necessity of the test, and do not show that you are annoyed. Instead, find out the reason they are refusing and show understanding and compassion and provide help. Allow expression of feelings without judgment. Remember, those who judge will never understand, and those who understand will never judge. Collaboration means you talk with instead of talk to your patients. Ask your patient's opinion and proactively encourage questions and discussion. Be open to learning from your patients. Trauma-informed services foster patients' self-efficacy, self-determination, and control. Empowerment means you come up with mutually acceptable treatment plans. You give choice and control over decisions to your patient. This applies to your staff as well. There's much more, but I hope this has given you a glimpse into the experiences and needs of dry eye patients and how you can effectively help us by providing excellent holistic and personalized care. I believe that the better the care is that you provide, the more fulfilled you will feel by your work. I would be happy to hear from you if you have any questions or comments. My email address is here. Thank you for the work you do. You are so needed.